Hi, welcome everyone. Appreciating that it's now 1:30. Just going to give it another minute for any latecomers that aren't used to using Teams, etc. So the plan will be to start at 13:31. Can I just remind everyone just to go on to mute, please? I can just hear some background noise. Thanks. Okay, then I think we'll start the event now. It's 13:31 and we've got near enough 100 people on the call, so welcome. So welcome to today's NHS Midlands Learning from COVID event. This is an infection prevention and control focused event. My name's Deb Adams and I'm the Assistant Director for Infection Control for the Midlands, alongside my colleague Kirsty Morgan. And Chris Morafrost and I have developed this study session. And Chris is the Urgent and Emergency Care Clinical Lead for NHS Midlands. You can see the agenda on your screen at the moment, and I don't plan to go through that because you can quite happily read that. Before we sort of go on to it, I'd just like to give some background. So NHS Midlands are privileged. Oh, can you go on to mute, please? NHS Midlands are privileged to attend all the COVID outbreak meetings. So we've tried to develop the agenda around the lessons that we've learned with some of the major contributors, and to get that message across, because one thing that we appreciate from the meetings that we attend is that there is often a challenge between infection prevention and control and being able to deliver it, and bed management and operational management, especially around sort of like the 2 metre social distancing. I'm sure some of you that have had outbreaks, you've seen outbreaks associated with the trying to put 2 metre social distancing in clinical, non-clinical, as some of you noticed at the moment, also the social events. Whilst we've hoped to capture a large amount of scenarios, we appreciate that we haven't been able to capture them all. We have got a great lineup of speakers who I won't introduce. I will ask them to introduce themselves to make time. I just want to go through the housekeeping points. So, etiquette. Please maintain your mute and silence. Put your phones on mute and this on mute, and please don't turn your cameras on because it shortens the bandwidth. Use the comments box to ask any questions. We will follow up on any questions you ask. We will use these questions to also formulate the Q&A session at the end of it by using those questions that you've posted and those that you've already emailed to us, which we really appreciate. Just a reminder that this is being videoed because we will be using it at a later date. I think that's covered all the key points, so thank you for that. The first session that we're going to start with is Paul Galloway's session, Forgive the Patient Experience. So thank you, Chris, for working in the background. It'll be over to Paul now.
Morning. Hi, so my name's Graham Jones from Ambulance Service. I look after the staff testing team, and I'm joined today by Paul Galloway to talk about his experience of COVID over the past few months. So Paul, you've worked with West Midlands Ambulance Service for the last 10 years in a patient-facing role, and back in April you were sent home from work with a mild temperature and then tested positive for COVID. What was that first week like in terms of the symptoms?
It was a bit strange really, because there was no symptoms at all apart from the temperature. As far as I was concerned, it was going back to home and living it out for the week.
Okay, fine. So no concerns or worries?
None whatsoever.
Okay. And I understand that you had a really minor bump into a stationary car during just coming to the end of that first week. What happened? Can you tell us about that?
It was just literally a low-speed bump into clipped the corner of a parked car. The husband's wife came out, disappeared again, came out and said she called an ambulance. I said there was no need. It was a low speed incident. No airbag deployment, no nothing, no injuries. I was fine. She just said, "Well, you don't look very well. You need to go to hospital." And I walked round to my house and waited for the ambulance.
Okay. And what were they concerned about? What was the worry?
I just didn't look well.
Okay, fine. Do you remember what happened next?
I got onto the ambulance. They obviously did their basic checks, alerted me into the QE, where we bypassed A&E and went straight into ITU.
Okay. And do you remember much about what happened next then?
It's all a bit vague, but I remember transferring into a chair in ITU, at which point I collapsed, passed out, and then I was put into an induced coma for approximately 3 weeks.
Okay. So quite a long time. And what do you remember some of the more difficult and challenging things that you experienced in hospital or in ITU?
Initially, my physical well-being, having to learn to walk and talk again, and seeing the stress and strains that the nursing staff are going under from the inside.
Okay, so that was difficult as a healthcare worker to see.
Very much so.
Were there any positive things that you remember from the time in ITU?
Communication. They were very good at the end of each day, or if needed, they'd contact my mother, who could update everybody else, and the general care and communication with me and the nursing staff.
Yeah, which is a really interesting point. And I think some of the things that we talked about is, as clinicians, we often use lots of non-verbal communication and reassurance and smiles to patients to reassure them. I was really interested about how PPE affected your relationship with nursing staff, what the experience.
Difficult initially because of myself not being able to talk, and them having to lip read and looking all the same.
Okay, and did that have a difference on how you felt on terms of how reassured you felt, or did you have difficulty hearing?
I had slight difficulty in hearing due to deterioration during the coma, but the way the staff were, they were brilliant and absolutely fine, couldn't fault them.
Brilliant. So your hospital journey obviously ended and you're at home now recovering, which is brilliant. What impact is COVID still having on you now?
Well, it's my fitness. Fitness is the main thing. Painful shoulders, which comes from being in the coma. And it's just outlook on life, things now. So it's changed a few things.
Yeah, I can imagine. And what type of an impact has it had on your family and friends? I've met your partner today and you've talked about your mum. How has it been for them?
It's been quite stressful for them as the QE is in a COVID lockdown. So there was no communication whatsoever apart from through nursing staff. As I say, which they did an excellent job.
Yeah. And do you still live independently at the moment?
I'm living with my partner at the moment, more so I don't need to use stairs. She lives in a flat.
Fine. And obviously that's quite difficult. What has it changed your outlook on life or your plans that you have?
Oh, definitely. It's got to get fitter, stay fitter, obviously make sure I'm working with PPE more and be closer to the family.
Yeah. And I suppose I suppose it must be difficult sometimes when you talk to friends and family about social distancing and, you know, the impact that COVID can have when you see that, you know, that isn't always happening or people don't take it seriously.
Family-wise, we're hot on social distancing, as my mother's 77. So it's all PPE.
Yeah.
I mean, obviously we don't walk around with aprons on, but we wear masks all the time. So it's very much up front there. And when shopping.
Yeah, I can imagine. Paul, I mean, you've had an extraordinary journey into hospital and your journey in hospital. It's amazing to hear about some of the positive experience that you've had and the care that you've been given at the Queen Elizabeth Hospital in Birmingham. I've got no doubt that you're looking forward to coming back to work, and we're looking forward to having you back in work. We hope that your health continues to improve. Thank you so much for joining us today to tell us all about your experience.
Thank you.
I am Paul. Thank you for that interview. Paul, thank you very much for sharing your patient journey and explaining the effect that that's had not only on you, but your mom and your partner, and how it's going to affect your life going forward. And plus, for me, the key issue that you discussed there as an ex-ITU nurse is how you communicate with your patients, with the PPE and all the limitations that has with it. So thank you very much for that. Moving swiftly on, I'd like to introduce Dr. Per Shah, who's going to discuss the primary care experience. Thanks, Per.
Hi. Right, I'll begin. Right, so as somebody who's a jobbing GP, also works in urgent emergency care and integrated urgent care, I'm just going to give you a bit of an insight into how things worked through this COVID period. Next slide, please. We know that Public Health England had worked with NHS England, NHS Improvements, and the Royal Colleges in terms of trying to get some insight into what's appropriate PPE. Well, that led to a lot of lingering, which led to a lot of anxiety, I believe. Multiple changes. There seemed to be an element of indecision, a lot of debate and conversation. Should it be gloves, face masks? What kind of face masks? FFP2s, FFP3s, surgical masks, shields, yes shields, no shields, aprons, or hazmats. So that led to a lot of anxiety and a lot of difficulty in terms of what should be bought, what shouldn't be bought. And I saw that from the point of view of the CCG and saw their difficulty in trying to chase that PPE, and also from the point of view of primary care, trying to make sense of what they needed. And that was also reflected in the urgent treatment centres and the walk-in centres. Now, so that was one thing that was quite apparent through that initial stages of trying to make sense of PPE. And then the second element to this, how do we manage infection in a face-to-face environment? How do we manage our urgent treatment centres, our walk-in centres? How do we manage our general practices? How do we manage primary care?
Hi, this is Chris, the administrator. Pia, if you can hear this, are you able to check your connection? So it looks like we might have lost Pia, Chair. So I'll move the screens on to the next presentation, which is Mark Doherty. And if Pia can rejoin us, perhaps we'll come back to primary care.
Right, thank you very much for that. I'll go straight in. And my intention is literally just to whiz through the slides, and if there's any spare time, I'm very happy to answer questions. I have a dog that's lying by my feet snoring very loudly, so I'm hoping that the headset will keep that snoring a little bit at bay. So if you wonder what the noise is, that's what it will be. I'm not sure if someone's not muted because there is some background noise, but yeah, next slide, Chris. So here we see Graham again, Graham in action this time. So many of you will remember the face of the COVID initial outbreak. This picture is actually from the national newspapers from the 31st of January. And what it reminds me is actually things started to hot up long before we entered into lockdown. And this was Graham escorting people from Brize Norton to the Arrow Park Hospital in the Wirral, people that had come back from China and were going into isolation for 2 weeks. We'll go through to the next slide. The time frame was actually a very rapidly developing time frame. So you'll see that from an ambulance point of view, things started to happen around the 23rd of January. And we were getting guidance out from the 24th of January. And certainly when we look back, and it certainly felt this at the time, we seemed to be getting guidance every few days, every week, things that changed. It was a very rapidly changing environment. Next slide. And what that meant was that we were having to develop our own guidelines. We were having to translate national guidelines, and we were having to make sure that we were working to the latest guidelines. Next slide, please, Chris. And so this went on for the first few months from January through to probably around April, May, before we really got into a rhythm of what COVID and our response to it actually meant. I'm going to go through 3 headline stuff. The first is challenges, which is on the next slide. From an ambulance perspective, it was a very, very challenging time. In our world, it meant what we had to do was not only just keep the service going, because everyone still had the normal needs of an ambulance service, so people still had strokes and heart attacks. In reality as well, we had come from a number of national major incidents because we had lots of flooding in the West Midlands, and that had barely subsided before we were straight into the COVID national emergency. So what we found is that it was challenging, the guidance coming out and changing, and also when it came out. So we found that quite a lot of things were coming out, for example, on a Friday afternoon. It was difficult to maintain staff confidence, and I think Pierre alluded to this, that 1 minute we were wanting full level 3 PPE, the next minute it was sort of an apron and a mask was okay. There was also conflict between what acute hospitals were doing and what we were doing, and an example of that was in our patient transport service. We would arrive to pick up a patient for discharge home. The ward staff were in full level 3 PPE because they had areas where there were aerosol generating procedures, and our staff were getting confused and sometimes denied entry to pick the patient up because there was difference in interpretation. There was also, as we all know, there were challenges in the national provision of PPE, and it was just altogether a very fast changing environment. Next slide, please, Chris. We achieved a lot, though, very, very early on. So, and I will pick up on a couple of these examples. We very early on influenced a lot of the national COVID guidance that was coming out. We got involved in a lot of the specifications, for example, for the PPE, because what we were finding is that whatever guidance was coming out had to be translated into an ambulance environment. We'd been fairly fortunate in that a year before all of this, we had invested heavily in PPE. So, for example, on every ambulance, there were powered respiratory hoods, which meant we were very much ahead by way of preparation. Since COVID has come in, we've also introduced the process of Clorox 360, which is a electrostatic disinfection process. So all of our vehicles go through very thorough cleaning, and this is an added procedure for making sure that that disinfection is really robust. We implemented a command and control structure very early on. We had a dedicated tactical incident room, which worked well for us. And we did some very early staff screening, which I will pick up on in a little bit. Next slide, please, Chris. Lots of positives across the organisation. There's definitely a much higher awareness of the whole issue of infection prevention and control. The importance of that actually has been re-emphasised, and we've got a much better awareness of very simple things like hand washing. We've also got some really good engagement across the health economy and with our public health colleagues, and also across the ambulance sector. You know, it's really come together to work collaboratively in order to make sure we've had a robust response to the COVID. We're now issuing, as personal issue, the respiratory hoods for our staff. We've got much improved provision of PPE generally. We've got a better feel for pandemic planning going forward. And altogether, we've just got a much more robust estate, vehicles, staffing, and actually for going forward, we're in a much better position. What I will do is go into a little bit more detail in some of the things that we did specifically. So the next slide highlights one of the things that worked very well for us. Because things were changing so quickly, we had to have a mechanism of communicating with our staff. We found that by issuing clinical notices, staff could keep up to date with what the latest requirements were. So this is just the front page of a clinical notice in relation to level 2 PPE, which is the picture on the right, and level 3 PPE, which is the picture on the left. The whole document outlines the detail that staff need to go through. And as you can see, this was one of the later clinical notices issued in May. We kept a central repository of the clinical notices so that at any point in time, staff had access to the most up-to-date. And we published these every Thursday. So the latest ones staff knew would come out every Thursday. The next slide. This slide illustrates some of the challenges with PPE. So the picture on the left, these were flimsy aprons, they weren't very long, and they blew in the wind, which meant a paramedic going outside that had been protected suddenly gets a face full of a flimsy apron in blown up. So that was less than acceptable. We're not saying the aprons weren't of use, but they weren't of use in a pre-hospital environment for us. Equally, we had masks issued that as soon as they were put on, they disintegrated. And we all recognise that this has been a big learning for everybody. So what we did about the aprons, we actually had bespoke aprons made that were thicker material and longer, and they're in use now. The aprons that weren't suitable got redistributed. Now, early on, I spoke about staff swabbing. We had 1,000 staff off the first week in April. We needed to get them back to work, but at that point, there had been hardly any staff screening in the NHS. I'd previously run a pathology service, and I thought, well, the technology is similar across sexually transmitted illnesses by way of the PCR test that's undertaken. We found a company that would supply the testing kits. We sourced a private laboratory in Leicestershire, and over a period of a weekend, we got near on 1,000 staff screened and most of them back to work. So that was just an example of how we had to work creatively to solve a problem, and it worked very well. And I'm very happy to take any questions.
Mark, that was great. I think we'll take questions at the end if you're able to stay online. That would be great. Just following up on one of the comments that you made, I agree totally that infection control awareness has significantly improved. I don't think we've ever been on top of everyone's agenda like we are at the moment. Right, what we're going to aim to do is backtrack and go back to Per's presentation now. So, Chris, are we all set up for Per?
Yeah, as long as my internet doesn't fail again.
Brilliant, thanks. I'm going to go on.
Okay, so if we go back a slide. Right, so yeah, so the BMA issue, just wanted to bring it up because obviously a large proportion of our primary care staff is of BME background, and there was a lot of anxiety and still continues to be anxiety around face-to-face assessments. and I think that's something that we're beginning to work out. But obviously IPC becomes very important in this kind of environment, and trying to really give the BMA population a bit of confidence, our colleagues a bit of confidence in how to manage these situations. And I think what it did allow us to do in primary care is it allowed us to look at digital solutions and really look at a different way of working. So next slide, please. So we've touched on different areas: general practice, urgent treatment centres, walk-in centres, and even out of hours, which are all sort of GP-led services. But primary care per se, again, what's happened, and in many ways, what you've had is a bit of a an evolution of a completely new service, really, which is completely digitally led. And this, it's taking years for us to actually get there, and suddenly, within months, this has happened. Next slide, please. Next slide. Yeah, thanks. So, what were the issues? What were some of the things that we need to address in general practice or primary care? How do we manage vulnerable patients? How do we manage low risk and high risk staff? How do we manage our care homes? How do we manage our patients who are shielding? So there's a whole gamut of complexities that were now added to primary care. The first one being, well, do we open our doors or keep them, or close our doors? And how do we manage our flow? Now, so that was one element. On top of which, there was childhood immunizations that was a concern. How do we manage our wider community? How do we engage our wider community? So there's a plethora of questions that we've now had to attempt to answer, and I think some of my colleagues have done a very good job of this, to be honest. Now, and on top of all that, what we decided, some of our colleagues did. They looked at 3 specific areas. The immediate focus of IT was IT, infection control, day-to-day running of the staff and the patients. Next slide, please. So IT was tackled, and the reason IT was tackled is if you manage the IT well and manage the digital element well, you manage the flow into practice as well. But you've got to make sure it works for the patient, and the patient is pivotal to your IT developments and your digital solutions. So in this case, Microsoft Teams was used for all your meetings, for MDTs, for working with secondary care, communities and care homes. Teams are also used to good effect with patients and also with patient participation groups. So Broadway, which is a medical centre based in Birmingham, used Teams quite effectively. And this is some of the presentation I'm presenting today comes from their solutions that they've already developed. So patient-centered services, they've actually got the patient participation group involved in their solutions. Next slide, please. In terms of the staff, they managed staff. They looked at their risk. The CCGs helped. They offered them laptops. They allowed minimizing their hot desking, telephone handset use. You had your own phone. You had your own laptops. You weren't sharing equipment. Staff were provided full PPE and scrubs. Alcohol gels were made available in clinical, non-clinical areas. There was continued purchasing of what PPE was available. And remember, at the beginning, it was all a bit of things were very vague. So a lot of practices had to find solutions to some extent at times for themselves. Risk assessments were done. Staff rotas were created. And high-risk staff work at home. The low-risk staff from practices. An emergency cover was on standby. Reader-centric Unity desktops, so apps were used to help communicate between staff and patients. Next slide, please. The font's not great there, but the kind of solutions that were found were things like Red-centric, Unity app, allowing for staff to communicate in a virtual environment on their own laptops, but as if they were working in the practice. In terms of MDTs, again, Teams was used, but they also used something called Patient Leaf app, which allowed to summarize the notes on a single, literally on a single sheet, which allowed for efficient communication between secondary care and primary care about cases that they went to discuss in a diabetes MDT or a respiratory MDT or a frailty MDT or a palliative care MDT. Patient chase application is another app that was used. And again, this was to support the practices, new ways of working, minimizing the number of contacts that each patient requires. So in this case, if the patient did require a number of tests, then they could all be done in one visit. So really, in a way, looking at the patient holistically and managing them very efficiently. The GPs at Broadway, for example, use dual screens, allowing them to actually, in many, multitask quite efficiently and actually use other apps and software while they're trying to manage their patients. So all in all, a very different digital solution. Next slide, please. Now, in terms of infection control, well, how does all that IT development help infection control? Well, if you've got good IT development, good digital solutions, you've got your patients engaged and your secondary care colleagues engaged and your other partners engaged in the service, and they're all using digital solutions, it decreases the flow into your practice. But the patients still get managed relatively well. So in this
1 minute warning.
Right. So they were fortunate enough to purchase PPE. They reviewed their infection control process, cleaning schedules, and isolation room was created. Hand washing and alcohol gel posters were displayed, and deep cleaning took place, and all the cleaning was audited. Next slide, please. So similar with UTCs and walk-in centres, they had to redefine their roles. In some cases, they had to close some of them down because of the logistics, and others continued, but with a completely different flow management. Next slide, please. A prime example is Walsall Manor, where the clinical managers Simon Hipkiss and Michelle Rowe worked very effectively with the team and managed and made sure that they minimized face-to-face contact while still managing the patients well and effectively. Next slide, please. CCGs would like to point out had a lot of issues around PPE, and they had to clarify what PPE was available, chasing PPE, delays in PPE, but then still, after all of that, did a pretty reasonable job of making sure that some PPE was available now. Next slide, please. So what have we learned? We've learned that there are processes now in place that we don't want to lose. IPC is pivotal to primary care and all front-facing healthcare. And we need to learn that what we have developed and is working well, we need to keep. So portal for PPE, enhanced cleaning processes in practice, digital upgrades, new ways of working primary care, we all have to keep. And what we have to think about moving forward, and what we learned from this process is we need clear, on-time and detailed communication coming centrally that allows us to work much more effectively. And I think if there's a concern, the concern was right at the beginning when there was a lack of clarity. But I think we're in a much better place today than we were right at the beginning of this COVID-19 situation, especially in primary care. Thank you.
Thank you very much for that. That was great. And just to echo what you've already said, I think COVID has taught us a lot on how to work differently and improved, and we've got to hold those lessons learnt. So thank you for that, Per. I'm going to move swiftly on to Jim Davidson, who's going to do the IPC challenges in ED. Thanks, Jim.
No problem at all. Thank you very much. Good afternoon, everybody. My name's Jim Davidson. I'm an A&E doctor in Coventry, in the centre of the region. I'm also the regional clinical advisor for emergency medicine, so I've been involved in a number of these. Time is short, so we will press on. So my experience is describing the effects in a big ED. Coventry is a big ED, but also from the sort of shared experience of our regional clinical leads in emergency medicine who've sort of met on a regular basis throughout all of this time to share what they were finding difficult and what they're having problems with. And I'm going to describe it really in three phases. I think for EDs, there were three phases to learning how to deal with this infection, then how to refine the process as the numbers increased, and now actually almost a more complicated problem of how to maintain good quality infection control process and procedure against the competing demands that EDs are now facing. It all feels a long time ago that we opened the first coronavirus pods, but certainly things have moved on since then. Chris, next slide, please. So the learning phase was really quite a challenge of rapid evolution. I think there was a huge amount of advice coming out over those first weeks where initially people struggled to understand how this disease was evolving, how it was impacting on us, and what sort of volume of activity we were going to have to undertake, certainly in the January-February period. And there was a lot of change to that advice as it came through, and I would echo what Mark described of some frustration that often that advice landed on a Friday, and then required teams to process that and localize it to their own services over a weekend before it could then be implemented the following week. But there was a huge volume of information, and some of the challenge for locations such as the ED was that actually the advice and the evolution as to who could have COVID changed often in a fairly inconsistent manner. And so you could go from one day from nobody from a certain part of the world or a certain part of a country having any possibility of being considered as having COVID as an illness to the following day, absolutely they were at risk group and needed to be isolated and dealt with in different ways. And EDs had choices to make, and they could either get ahead of that advice and isolate and deal with people in a infectious way earlier, or they could follow the national advice. And in the main part, EDs went for following the national advice process, accepting that there would be small groups of patients that were being missed up until the point that advice changed. Very quickly, we all had to work out how to develop comms pathways for rapidly changing advice and information. Emergency departments are complicated systems. They have huge numbers of staff groups, they have different staff groups, and they have often very complicated shift patterns. And communicating across multiple shift starts with new advice, changing advice, can be quite difficult. And so one of the things we found very positive was moving to much more simplified shift patterns. This is contrary to most ED operational demands where you match your activity to your staffing, but actually there was a need for us to move away from that so that we had clearer demarcated start and finish times so that we could brief staff. Kits changed fairly rapidly. The requirement, certainly in the early phases of this illness, to constantly fit test people for new kit as it arrived was slightly time consuming. But actually over that initial period, once that was done, that became much more straightforward. And the rapid change in numbers going from really very few numbers that could be managed through one or two pods and one or two locations through to much greater numbers that needed departments to be reconfigured in short order was difficult. Realised early on that within any closed systems, with an ED system, you needed to have a single version of what the truth was. And actually, we used a single paper-bound, laminated folder of this is today's version of how we deal with COVID as an illness. And if it did, when it changed in that folder and was then sent out through a multiple route of other channels. We set up WhatsApp groups for all of our staff so they could have that information shared with them. We used email, we used notices, we used things stuck to backs of toilets doors, but this one single version of the truth could be held as a central repository so that everyone knew where they could go if they were unsure as to what their current advice was on what PPE they should be wearing and where it should be. We use PPE champions in the early phase of the illness. It's amazing what you can do with a tabard or a flash of something across somebody to empower them to ensure that people are wearing PPE correctly and changing it in the right way, and went through lots of practice of donning and doffing so that all of our staff got up to speed very quickly. And very early on, we realised that you had to engage your estates department. So within an ED setting, we realised that all of our patches would have to change into areas where we were treating COVID and areas that we weren't treating COVID. And for some departments, that may be entirely separate areas, or it may be in smaller departments, different areas within the same physical structure. And so getting your estates department on side and talking them through what the challenges are likely to look like was really important. Next slide, please, Chris. One of the things we found really invaluable was the use of plastic sheeting. Plastic sheeting to make doorways meant that you could redesign the department very, very quickly, and the estates teams could throw this up in no time at all. For a short period of time, we had a hard barrier, a hard wall with plasterboard and studding. Plastic sheeting was much more straightforward and much, much faster. Next slide, please. Then we moved into the refining phase. And by this point, I think the volumes had increased sufficiently that departments were reconfigured into their final resting place, really, for the bulk of the period. We had almost all managed to put in consistent streaming criteria. A lot of the infection control activity, I think, that had the greatest protective effect for patients and for staff in ED settings was less around the patients who were actually coming into the department, but the patients we were keeping away from departments. So this could be patients who we were deeming to be low risk, who could be treated at other locations, by other services, in other parts of a hospital, or at other hospitals, at urgent treatment centres, or remotely through their GPs. And most of our EDs, and certainly mine, adopted a sort of a fairly aggressive streaming criteria for patients who had no evidence of COVID illness. Now that's complicated by the fact that we know that some patients have entirely asymptomatic COVID, but it had to be based on something, and so the presence of respiratory illness was really what guided that. PPE advice by this point had become consistent. No problem, I'll speed up. PPE advice had become pretty consistent, and all of the adjunct pathways that hospitals have put in to help support their ED had really worked. We did all of our streaming with a consultant. We run a consultant streamer doing it 24/7. And there were good processes in this phase for national and regional sharing, and we ran a weekly regional clinical leads meeting. Next slide, please, Chris. We'd implemented handover with social distancing, which worked well. Our junior doctors had asked that we move to a clean and dirty buddy system so that two clinicians, that could be a nurse practitioner and a doctor, or two doctors, or two nurse practitioners, would see a patient together, one in the room, one out of the room, to reduce in and out of room movements. The consultants considered deliver streaming, and flow within ED was really key to us being able to deliver a no-wait emergency care pathway, which reduced the risk of patient-to-patient transmission and allowed us to look after patients in secure areas. Resus remained a challenge because actually dividing resus areas up was much more difficult. And so almost all of our departments moved to all resus was potentially COVID positive. Some real challenges delivering resus with full PPE on, mainly around the acoustics of how you deliver particularly major trauma with full face mask and visor on. But clear direct advice and statements, I think, made that much more straightforward. Next slide, please, Chris. And next slide again. And then we moved into the maintaining phase, and I think the step up was much easier than the step down, and trying to work out how to redesign your physical estate as the quantity of COVID illness has been decreasing, but there is still an absolute need to protect patients within patient streams. And how we are doing that, I think, is much more difficult. Hospital occupancy has increased dramatically over the last few weeks, and that means that flow out of emergency departments is much more difficult, and we're starting to lead to a degree of crowding in EDs, which is starting to introduce infection control risks as we find ways of clearing patients. And goodwill within services that were streaming patients away from EDs is certainly starting to slip. Next slide, please. The positives are that the learnt experience has been dramatic, and we will carry this through into the winter period, into the flu season, I think, and have much better understanding of how we look after respiratory infection control, but infection control in general. And the ability to share this experience across the ambulance service, the emergency departments, and into the hospital setting has been really better than any other experience I think we've seen with infection diseases, SARS or swine flu, or the sort of impact of the Ebola crisis that impacted a little bit on us in the UK. We are really struggling with maintaining discipline and maintaining discipline around PPE, particularly for teams coming into an ED setting. And there are certainly conflicting priorities for the hospital world around elective work versus non-elective work, and how we maintain flow through our departments. And then final slide, please. And so we're not quite sure what the future looks like. This is an example of what we think our waiting room will look like. It's not the most welcoming space. It's certainly not a space that we think is going to be dreadfully useful to us. And so providing emergency care in a way that keeps patients safe by not cohorting them together, by enabling them to keep separate and to move through a system where they're not being exposed to patients who may have COVID if they are not, or if they're a shielded patient. And equally, keeping patients who have presented with respiratory symptoms safe from other patients is going to be a particular challenge as we come into that. But that, I suppose, is our experience so far. I'm very happy to take any questions. Please do leave them in the chat box and I will pick those up as soon as I can.
Thanks, Jim. I love the idea of having the single version of the truth folder. How true that is. Right, I'm going to have to move on. Just a reminder to put any questions in the chat box. So now I'm going to hand over to Michelle Rhodes, who's the Chief Nurse at UHNM. Thanks, Michelle.
Thanks a lot, Deborah. Thank you for inviting us. The infection prevention team and myself have pulled all this slide together. So I agreed to present it. So thank you for the invite. It's quite interesting to hear everybody else's presentations, and there are some themes there, and I'm sure you'll pick up the themes from our presentation as well. So from an acute organisation, UHNM, Stoke and Stafford, 11,500 staff. 1,400 beds, major trauma centre. For us, the title of "Don't Panic, Mr. Mannering" is, I'm sure, a lot of people thought. We did have a bit of a panic. If I'm honest, there was a bit of a panic at the beginning, thinking, "Oh dear, we this is all very new. We've not done it before." But fortunately, we've got a very experienced exec team here and a really experienced IPC team that enabled us to set up our incident command centre quite quickly. So that was, of course, a gold and a silver, which we called our tactical. And the one thing that started this off for us about how quickly we could get IPC involved was that all the comms that were coming from the centre were coming through the ICC. So they came through in the incident command centre rather than to the DIPSI or to the nurse or to the medical director. So to start off with, I was getting it, fortunately, from NHSI and NHSE, but it was also going through another route as well. So it was clear to us right at the beginning we needed to get IPC involved in both gold and tactical, and our health economy group that we set up, plus the clinical group, which we'll talk about a bit more in a minute. So the first bit was getting, and Jim's just described what they did in ED about splitting the pathways. We had to do exactly the same, and IP were involved in all of that, and myself as the DIPSI and the Chief Operating Officer going down, walking the pathways so that we could understand it as well. Plus the ITU capacity for us, we were looking at super surgeon being asked to go up from 52 ITU beds to 160. So it was a massive challenge about PPE and closing theatres down, and Amir, our lead IPC nurse, Deputy DIPSI, him and the team all the way through this, trying to get this sorted out. So ED and ITU started off as being our big issues to sort out, and we also had the pod gate, as we call it. Are we having a pod at ED? How far is it away? Who's going to clean it? Who's going to police it? Is it going to be safe? How about security? Are we going to get people going in there for having their lunch? Do we need to, and all of that. So all of those things IP got involved in. They had a very sensible head and approach to it. And I have to say, from that first point of view, Keith Willett's call every Thursday was massive. It was massive for me, for the rest of the team, to be able to hang on to something that was coming out nationally. So the second part around clinical engagement, we set up a clinical group which met daily, chaired by the Deputy Medical Director. It had infection prevention as part of that team, microbiology. Because we've got infectious diseases unit, we had our infectious diseases physicians on there and the chairs of all of the divisions. And that was key to us because everybody said already the guidance came and went, and then something else changed. And we used that clinical group as a way to go through it, have the conversations, look at the evidence that was there, particularly because we had also different evidence coming out from the colleges at some point around PPE and some of the other issues. And so they were able to look at the information and then recommend the answers up to gold for us. I mean, it was quite clear that our infection prevention team was going to be spread too thinly. So Amir, our lead, restructured the team. Quite early on, the university took our students because they didn't feel they could be placed safely. And so from the corporate nursing perspective, we had a group of nurses that used to manage and look after the students that we were able to put into the IP team. And with them, Amir had a bigger team and was able to create a COVID-19 cell for IP. We had a COVID help desk, and what Amir put in place was operational and strategic lead. So he was the strategic lead, sat on tactical. I sat on gold with him actually as Dipsy, but then also an operational lead that was around the wards helping people, offering support, answering the help desk, and that was for 7 days a week. Obviously IP fed into all of the comms around that as well, so they did all the training videos, all the posters, the fit testing and everything. We also set up a team, which I think it's a couple of other people have mentioned, but the IP were part of, that supported the care homes. So we were very clear in the way that we look at this in our health economy is that there's only one set of patients. They go in and out of different environments, but there's only one set. So quite earlier on, we were asked by the local authority and some of the care homes for mutual aid around PPE, which of course we offered. But then we set up a small team that included a quality nurse, somebody from the IP team and somebody from our rehab team that went out with the local authority to visit nursing homes, train, offer support and advice. And they had fantastic response from the care home. So that's something that we'll definitely keep going. And all of this time, the IP team were trying to keep an eye, as we all were, on our C. diff and sepsis and all the other issues that were happening as well. The other two bits on there, we have a big lab here at UHNM. Early on we were working with microbiology as to what capacity or how much swabbing we could deliver, how much we had, and it was a bit frustrating for us to start off with because we have quite a lot of capacity, but we didn't feel that it was used nationally. We weren't seen as one of the sort of the big labs where actually we did have a lot of capacity, but we did sort that out fairly quickly. And then we have an infectious diseases ward, which was all prepared, ready to receive the first patient. And we did receive our first COVID positive patient on March the 3rd, and that was a transfer from another hospital that we were helping out. Next slide, please. So the things that we really had to deal with were emptying our beds. So we were told to empty our beds. We had to work really closely with the community to discharge patients safely. IP team were in there reviewing the bed stock, looking at bed spacing. Myself and Chief Operating Officer walking around the wards with tape measures, along with the IP team, literally measuring bed spaces, looking at what we could do and what we couldn't. And we did manage at one point to have over 500 empty beds waiting for COVID patients. I can't emphasise the importance of comms enough, really. It was absolutely massive to us. We just internally with our staff, we set up a weekly Facebook page, and all of the questions, weekly Facebook live session, all of the questions on there were about, to start off with, were about PPE. So there was loads about PPE and about shielding and that kind of stuff. So we spent a lot of time talking to staff. Like Jim was saying, we
warning,
also,
Michelle.
Thank you. We spent loads of time out there with tabards on around social distancing, and did lots of work on all of that, getting to talk to people. We suspended visiting quite earlier on, which I have to say I think was the right decision at the time, although it was very difficult. Like, the other thing I can't emphasise enough for us was about public engagement and support. The public were frightened and are still frightened to an extent to come in to us. We did see our numbers drop off massively. But the other thing I would say about that is be careful what you wish for. So an example of that would be that there was a big national media campaign around how tired staff were and how they were working long hours. And the next day we received 11,500 cans of Red Bull. So there is something about the lorry loads of hand cream and all the other stuff that we got. You just needed to be really careful when we put out on commons. Then it was a big battle waiting game for us. So we waited and waited for our patients to come in. And of course they did eventually, but all that time you overthink things and worry about what's going to happen next. Next slide, please. So the IP issues, PPE, everybody's talked about, fit testing, the just-in-time supply, getting different masks, having to refit tests, masks for people that failed, and all of that, the changing guidance was really difficult to handle. And IP spent loads of their time doing that. The constant changing guidance was really difficult for shielding and for PPE. Being in a level 4 incident, I've talked about already, everything went through that channel. The AGPs we've talked about as far as PPE goes, and the RCN change it, the Royal Colleges changing what they had as well. And I think from a staff perspective and their concerns, they had lots of fear and anxiety, and the constant changes, I have to say, didn't help us because staff lost some confidence in us, I think, at some points, because the guidance was changing so quickly. Next slide, please.
Michelle, I'm going to have to move you on. We've run out of time.
Okay. Can I just do the last one?
Yeah, very quickly.
Okay, so if you go to the last slide. So leadership, for us, the lessons learned were about leadership, being visible, being out there, and from a personal perspective and a staff wellbeing perspective, you know, not to be frightened to say, actually, I'm anxious, I feel like running away from all of this. It was helpful to have lots of networks and support. So we learned a lot, and we'll be certainly much better prepared going into the future. Thank you. Sorry I went over.
Thanks, Michelle. That's great. I'm going to move swiftly on to Mark Garvey at University Hospital Birmingham. Thanks, Mark.
Cheers. Let me put my video on as well. Can you see me? Okay, so my name is Mark Garvey. I'm a consultant clinical scientist and deputy DIPSI at University Hospitals Birmingham. If you jump on the next slide. So today I'm going to talk about the acute trust recovery. It's a massive topic, and I think there's several people who've already talked a little bit about their experience, what will overlap with this. This is really just to give you ideas of what we've done, and if you want any information, more than happy to contact me and I'll give you some of the information. So just to give you a scope of where we were, at our peak we had 708 inpatients with COVID, and that's down to you know, active symptomatic patients that's down to 20. So we had a lot of cases. We've had over 3,600 patients with COVID to date. You look at like our daily positives during the peak, we had up 145 patients with COVID, and you know, that's right down nowadays, although we still see, you know, the odd cases, and we'll probably will do. Our ITU, the number of cases we had on ITU was up 171 cases, and that's dropped down. So you can see that we've been in a position where we've had a lot of COVID. Next slide, if you could. And that just gives you an overview of how many patients that we've had to date, showing how busy we were. So next slide. I think really from going from everywhere really, realistically, I think it's to understand these key interventions. And I think when you move into the recovery part of you, it's to the recovery point of view, it's understanding these things and applying these IP principles. And I won't go through those in detail. You're all familiar with there, but you know, identifying symptoms is important. Hand hygiene, environmental cleaning, isolation, PPE, the use of face masks is a big thing. As you can see in the slide, what's a piece of work that we've produced, what's going through publication now. When we moved over to surgical face masks for everybody as per the guidance at the very beginning of April, the number of like hospital onset cases that we saw and COVID cases, it dropped dramatically down. You know, screening is a big thing, picking up asymptomatic carriages that are inpatient screening. Social distance is a big thing. You know, we're obviously staff have touched upon restricting visitors. That's important, and thinking of different ways of how we can work virtual. And so I think you just need to maintain these principles when you look into the recovery. Next slide, please. Next slide just details a little bit about UHB. I think people are probably familiar with that, but it's a massive hospital that consists of 4 hospitals. Now, it's important to talk about these, the 4 hospitals. Next slide, please. When you look at the sites, what we've done, a big key thing realistically is we've looked at the leadership, and we have daily strategic we've had daily strategic meetings, and one thing we have put in is that we had senior responsible clinicians per site. And when we moved into the recovery point of view, and this is before the guidance came out, we reviewed all our sites and what we could do really around the elective surgery. And what we've done from an elective surgery point of view, we've made Solihull our green, our elective surgery pathway. Patients who require major elective surgery, require critical care, we've done that through the QE, because the QE is, obviously a new build, was designed for outbreak management. So, we've got, we've got, over 100 critical care beds. We've got pods what we can split off as well. So, and that's what we've decided from our elective point of view. Next slide, please. Next slide, please. So from that point of view, this just gives you an overview of, Chris, if you can just click through the slide presentations, because it's a pop-up one, and this gives you an overview of some of the standard operating procedures that we've undertaken from looking at our elective pathway. And it's, obviously we've based it on the NICE guidance, but it gives you an overview of what we've undertaken. So we've obviously split it into major surgery, what's undertaken at the QE, and then obviously low risk surgery at Solihull. And then obviously we've looked at like endoscopy and other planned procedures as well. Things that we put in place at Solihull in the QE, we've got a drive-through for our swabbing service before the patients can come in for the elective screening pathway. So we had to consider all these facets, and it's vitally important you have good leadership in operational, and this is all built from the strategic point of view. Next slide, please. And I think really looking at it from a whole, on top of that, we're still seeing daily COVID cases, and so the hospital management of COVID is vitally important. When we have cases, we aggressively manage these. So we move the patients into side rooms, we cohort. It's important. We have importance of triage, as I mentioned before. We have daily site meetings to discuss the flow, because if the hospital gets closed down from hospital onset cases, then we can be completely stuck from that point of view. So we need to make sure that's vitally important. And we follow some of the framework that's come out helpfully from NHSI. We lock down our bays, we aggressively test and trace, and we've had minimal hospital onset cases. Next slide, please, Chris. As you can see, just to reiterate, a piece of work that will be soon published is around our multidisciplinary team looking at flow, and the number of hospital onset cases has reduced right down. And these meetings, these daily meetings on all the sites, really help from when we move into the recovery and what we can undertake. So if you go to the next slide, Chris, again. So I'm not going to go through all the different specialities, but there's huge amounts of work that we've undertaken from that point of view, and looked at all different areas. Could you jump onto the next slide, please, Chris? So when you look at it, you've heard a little bit of talk around ED. We've focused on the estates and triage within that, critical care. We've moved the whole of critical care from what it was a COVID ITU back down to normal COVID. We've looked at the cancer pathway. We've looked at we've looked at the different services, and we've moved the services to different sites. So, for example, vascular diagnostics has been a massive backlog, so we've reopened that and had designated leads for all these different areas, as well as outpatients. So, and maintaining those principles of infection control. Obviously, I've talked about the elective pathway. Emergency, obviously emergency is still vitally important for that. Make sure we screen patients who come overnight admission, and make sure we maintain the APC precautions within that, as well as the theatre flows, screening and stuff. Fabulous. And then if you look, we've got an overview of the our Trust Intranet, what's got all the different pathways we've got through that. So next slide, please. Thank you. We talked a little bit about staff, and it's important to understand, and we've got a risk assessment and that guidelines for staff and an assessment. Next slide, please, Chris. And we've got that in where people can work. And really, from a conclusion point of view, next slide, Chris. again, it's to remember the IPC interventions, reverting back to normal, sort of back to normal, whatever normal can really look like with different things. Leadership is important, new technologies is important, and obviously more efficient working. So we've looked at working from home and real-time monitoring of the local situation. If you jump onto the next slide, Chris, talked about the conclusion. Can you jump onto the next slide? Yeah, there you go. So real-time monitoring, it's important here, looking at monitoring our situation so we could revert back to what we were doing before. So every week we updated, we're doing the elective work, our outpatient work, but we monitor the system. We have these maps and monitoring real-time epidemiology of the situation within Birmingham, for example. And then the final slide, if you go to the very final slide, when we look at it, it's a balance between measures to maintain safety and transmission of COVID versus delivering safe care for patients and avoiding significant delays in diagnosis and treatment. It's about being pragmatic and looking at the rigidity of the rules. They may need bending, like what we've done for endoscopy, in as much as we don't screen, but we do COVID symptom questionnaire when they come in to get through the backlog of the undiagnosed cancers that we've seen. And that's pretty much how we've dealt with it. That's all from me.
Thanks, Mark. I think you've done the sort of the three key things. It's down to teamwork, strength of your data, and having a pragmatic approach. So thanks, Mark. Moving swiftly on, I'd like to introduce Edward Quigg, who's the director of Bradwell Hall Care Home, to discuss their experience. Thanks, Edward.
Hello there. I'm actually the director of two care homes in Staffordshire and Stoke-on-Trent. So I can give two different viewpoints from each home. It's been a very, very different experience in each home. Bradwell is the large home in Staffordshire, which is 180 beds. And Trentham is a smaller home, which has got 60 clients in it in Stoke-on-Trent. And Trentham has had no cases, no positive staff at all, and virtually no symptomatic residents either. So a very different experience at Trentham to the experience at Bradwell. If you go on to my first slide. I'll keep going, next slide. Okay, so symptomatic clients. We started with our first client at the end of March. That's what the sort of the orange graph there is showing. All of a sudden in March, we had numerous symptomatic clients. We had more and more each day through March. That's the number per day rather than cumulative totals there. So we had a lot of clients through March that were symptomatic. And then we had some new admissions that started in April that were symptomatic. And that's when we started cohorting the residents then. You go on to the next slide, please. Okay, that's the staff profile. Very similar to the client group. Staff sickness followed, virtually mirrored the resident symptom cases as well. We had virtually no testing in March and April for staff, which is why there is so few positive tests on that graph. I'm sure of those staff that were off sick, a lot were positive, but most weren't tested. The ones that went to hospital weren't tested. Once they said they worked at a nursing home, they were told to be treated as positive and were mostly given an isolation note, which they brought into work or a relative brought into work most of the time, for them to say that they would be off sick and treated as positive, but they didn't actually have any tests at all through March, and I would say nearly all of April. We had virtually no tests for staff. Once they said they worked at Bradwell Hall Nursing Home, that was it. They were just told to treat as positive. We did the mass test on the 8th of June, which I think is about 4 weeks later than most other care homes did it. We were just very late in getting our testing kits here. That showed up 8 staff members who tested positive, who were in work, who we got absolutely no idea at all that they were positive. They were completely asymptomatic. So that was a shock to them as much as it was to us. It was different departments. One of them was a unit manager, there was domestic, there was housekeeping, there was all manner of different staff. It wasn't one team in one area. One admin member of staff who didn't have anything to do with residents at all. Since then, we haven't had any regular testing. There's supposed to be a new wave of weekly testing going on at the moment in care homes, and we haven't received any of those here at Bradwell, which is again very different at my other care home, which is about 5 miles away. So I don't think it's not like a different part of the country. And the other care home is now on to its 3rd week of weekly testing of staff. So the other care home does get the tests, and these are the non-Randox tests. The original test kits that we had at the other care home were sort of condemned, I think, and then we had to send those back, and then we got sent immediately another batch over at the other care home. Whereas here we get an email every couple of days telling us that there's a backlog on orders and we will get our tests soon. We haven't got a date for when we're going to get our tests here to be able to do the weekly testing. So we don't know where we are with that really. We're a bit in the dark, which is mostly how we've felt since the sort of the start of the outbreak, was that we've been in a bit in the dark. All sort of the media has been quite negative. We've been on the front page of a lot of newspapers, Sunday People, the Mirror, the Mail, the Express, the Times, the Telegraph, have all ran various different articles. We had TV camera spots at the bottom of the entrance. We had a police liaison officer to help with any kind of negative comments that cropped up. Underneath those newspaper articles, there was obviously various comments from the public, which prompted complaints to CQC. There was numerous anonymous complaints to CQC, mostly from members of the public just doing a random complaint that they thought people weren't being looked after, and they wanted the inspectors to come in and have a look because they'd read it in the newspapers. There's probably 6 of those just like that. So very, very little positive media at all, really, virtually all negative. Have the next slide, please. So this one is positive clients. On this one, we had some tests. We worked with the infection control team where I think Michelle was from. We had a good relationship with them right from the beginning. I have to say, them and Staffordshire County Council, we've had good relations with their team as well. We've had good relations with Public Health England. We had weekly meetings through April over Microsoft Teams with Public Health, Infection Control, NHS England were involved as well in those, and they gave us the sort of individual tests the infection control team did, which we did on asymptomatic residents because we couldn't do mass testing at that point. So we had low numbers of positive clients really, and then we started cohorting residents and at the end of April we created a designated area in the home. Okay, and we took positive admissions. So we have been taking positive admissions. That's dried up completely now, I would say. Nearly every admission now. I can't remember actually the last positive admission we had was probably mid-June, something like that, the last positive admission. Everybody else that's coming out now to the hospital is negative. And things that we've learned really is cohorting. It's a word we've never heard of before. We've never done cohorting before. The amount of PPE that we now purchase has roughly now buy 20,000 masks a month from none. They've been extremely difficult to get hold of. That's at the early days. That was buying from Amazon, from eBay, from random people who phoned up and offered us masks. whereas now we can actually get them from reliable sources. So that has changed a lot. I think that's probably it for me if we want to stop there.
Thanks, Ed. That was great. I think one of the things that we all picked up from that was the power that communications have, both positive and negative, and the impact that it can have on your services. So thanks for sharing that story with us, Ed. I'm going to move on to the Q&A session now. Hopefully we've got Lisa Ritchie, the National Lead for Infection Control, and Mark Wilcox, the Medical Advisor to the National Team, and Kirsty Morgan, my colleague, the Associate Director for IPC Midlands, on the line. I don't know whether you can put your 3 videos up, and then I'll go over to Chris. First questions.
Hi, Deb. Yeah, so there's a number of questions that have been received by email, and I'll monitor the chat as well. I know we're short of time, but I'll try and mix up the questions that we've asked. So here is the first question. What is the ongoing commitment to deliver 2-metre social distancing in hospitals and clinical areas when there will be an impact on bed capacity?
Mark, Lisa, would you like to comment on that from a national perspective?
I'm happy to start.
Thanks, Mark.
So, I mean, personal opinion, it wasn't helpful changing the messaging around social distancing when it was changed, but we are where we are. But 2 meters remains the goal in healthcare. And I think it's important that, you know, is that an absolute? Well, we know it's not possible to maintain that all the time, but if, you know, it's a risk assessment that as to whether that is deliverable or not. And we have other important interventions that can help mitigate that risk, which aren't, sadly, available to someone stood in a bar. Don't get me started on that one. But so we should aim for 2 meters. Clearly, in some cases, that may not be possible. If it isn't possible, there needs to be a series of risk assessments and mitigation measures put in place to reduce risk.
Thanks, Mark. Any comments from Lisa on that?
Yeah, I was just going to add to that, Deb, to say similar to after H1N1 situation in 2009, when we added respiratory hygiene onto the list of standard infection control precautions, I think the 2 metre physical distancing will become a standard infection control precaution for the foreseeable future.
I'd like to thank you both, because I know there's quite a number of trusts in our region. Their infection control leads and DIPSs are having challenges from the coups, etc., to deliver the bed capacity. So thanks for giving us your opinions and professional focus on that. Chris, can we move on to the next question, please?
Yeah, no problems at all. So next question was received by email. What are the plans to review infection prevention guidelines going forward as we try to deliver restoration?
Lisa, I think that's probably your baby to answer that one.
Yeah, so I think I'd like to thank any of you who have recently commented on a few different iterations of a revised guidance document, which is aimed to remobilise services, that we need to kind of support the system to restart services. So that is going through a publication process at the minute and due to come out hopefully at the beginning of next week. We have developed it into a 3-pathway approach, having a high-risk COVID pathway, a medium-risk COVID pathway, and a low-risk COVID pathway. And these are examples that organisations may wish to use. And I think Mark intimated that they almost had one whole facility that they could use as a green pathway, which is great. So they're examples for local organisations to adopt and adapt that what suits them going forward in order to get services back up and running across health and care services. There's a number of administrative measures that underpin all of the pathways and apply to all. And the way that we've kind of laid this new guidance document out this time round is really emphasising all the standard infection control precautions up front within the document. There are a number of key messages which we will pull into a communication plan and toolkit, and we're trying to put some visual aids together to make it easier for frontline staff. And then as we go through the guidance document this time round, we've set out, so what in addition to standard infection control precautions do you need to put in place for each of the different care pathways? So that is in progress at the minute, and as I say, thanks to any colleagues out there in the Midlands who have come back to us with comments. It's been really helpful.
Thanks, Lisa. Did you mention when those are likely to come out?
So the publication process is quite turgid. Is that the right word to use? So it needs to go through a kind of triple lock process. We're just starting that process now to get the document onto the gov.uk website, because you'll appreciate it is a 4 nations IPC guidance, not just for NHS England. So Monday, I would say, would be the earliest that we'll get that document out. Any information that I get, Debs, I will share with the regional IPC lead colleagues so that you've got the heads up and can share any of that with your organisations.
Can I just add a messaging point? Lisa knows what I'm going to say next, because we've done this sort of tandem, introduction of the guidance. The term downgrading PPE has been used on numerous occasions whenever this subject about modifying the IPC guidance, whenever this subject has cropped up. This is not about downgrading PPE. It's about taking a risk assessment approach, as Lisa's just explained. And for those people who need PPE, the healthcare workers who need to adopt PPE, there's no downgrading at all. It will be exactly the same as before. So the messaging here, it's a sensible approach to IPC given where we are now versus where we were in those very difficult times. Nothing to do with downgrading PPE. Over.
Back to Lisa, who's got a hand raised. Lisa, did you have anything else to add? You've got your hand raised. You're on mute.
Deb, shall I move on to the next question?
Yep, thanks, Chris.
No worries. So to both Lisa and to Mark, there are 3 questions in the chat. We may not have time to go on to all 3, but perhaps if you'd be kind, once we've done one of them, the other 2 you wouldn't mind having a look at. So perhaps we'll go to Mandy's, but there is one from Jeanette around A&E, and there is one from Deborah, around mental health. But Mandy's one is, what have we learnt regarding care homes, and is there any advice to care homes for the second wave?
Well, that's a very good question. I think the reason we're pausing here is that part of the sign-off process that Lisa has alluded to involves having to get DHSC sign-off, and we haven't yet got that. So in the ideal world, the guidance that Lisa has introduced will apply in care home settings. In the non-ideal world, it won't. And we're hoping that the former, but we can't confirm that yet. Worst case scenario, and it doesn't, then we're not just going to ignore things and just say, well, get on with it, nothing changes. We will work out another way of of having fit for purpose IPC, as in fit for purpose August 2020, as opposed to March 2020. But that's where we are in the process.
Sorry, Debs, I got frozen there and couldn't come off mic at all or lower my hand. So just to add to that, what Mark has just said, I would say that the IPC guidance that we have just drafted and is going through the publication process regarding remobilisation of health and care services is very much about IPC principles per se that can be, as I say, adopted and adapted across the UK. So those IPC principles, as we all know, are the same. Standard infection control precautions are standard infection control precautions, as are transmission-based precautions. What is really important is how we implement and apply those at a local level. And I know that Public Health England have developed setting-specific guidance for various areas, including care homes and others and such like. And so I think going through those documents and seeing whether any amendments need to be made to help support, but say the key principles for IPC apply across all care settings. And I think for me, if I can say, coming in as a new head of IPC, very much on my radar is a move towards national infection prevention and control policies that can be applied across the health and care system. And that, I think, going forward as part of one of the UK ambitions in the 5-year National Action Plan is where, would be really a good place to be across all of England.
Lisa, I think that's great. Having a national policy has been a dream for many infection control nurses. So thanks for that. Chris, next question and final one, probably looking at the time.
Yeah, so there actually is loads of questions coming through now, but perhaps Lisa, and if Mark's got time, once the session is finished, you wouldn't mind reviewing the chat. If you type a response, people will be able to see those responses after the session has finished. So last question was from Jeanette, and this was in relation to A&Es. So what are the plans regarding A&E waiting rooms? When crowding occurs, which inevitably will over winter, will patients be expected to queue outside?
Yeah,
good one. Well, if I was a patient who could stand up and needed to be in A&E, I'd be stood outside and asking to be triaged out there rather than in a crowded waiting room. I think masks, face coverings will be important in that setting, but that does not mean that IPC doesn't matter, because once you've got a mask on, that's it, that's all that matters. It doesn't mean that. But I think this is one of the reasons why we're trying to get people to think about IPC now and plan for the worst case scenarios, which include the winter with or without a second wave, and how we should be doing things to mitigate risk for patients, whether that's mitigate risk vis-a-vis SARS-CoV-2 or influenza or RSV and so on, because all of those viruses will muddy the waters with respect to the pandemic.
Lisa, would you like to add anything?
I don't think so. I think Mark's made all the points. I think what this pandemic has very much demonstrated, and someone said it earlier on, it's really put IPC in the spotlight, and we really need to start maximising that now, and mitigate as maximally as possible any risks across the healthcare system where we can see it. But we're heading into winter season with a perfect storm potentially. That doesn't mean we need to dumb down on any of the IPC measures that we've put in place.
I agree totally, and I think that's probably a great time to finish this session. IPC is now the focus, and that's got to be the prime vision going forward. Lisa, you've just raised your hand, or is that just a...
No, just to say, Debs, it would be really helpful, I hope you don't mind, if on the questions that they could kind of be captured and sent, and then I'm happy to look at them and respond.
Yeah, We can do that,
so
Lisa.
just so that they don't get lost and I forget to go back, and I know that teams kind of after 2 or 3 days everything disappears.
Yeah, no, we can capture that. And on that point, we've got 1 minute to go. So on behalf of Chris and myself, I'd like to personally thank all of those that gave their time to prepare their sessions and delivered their sessions in a timely manner. So that was brilliant. And to everyone that attended. We appreciate how busy everyone is during COVID and planning for winter. As Lisa suggested, we will pull all the questions together, collate the themes, and get a response out to everyone that's attended. So on behalf of NHS Midlands, I'd like to say thank you and goodbye.
Thanks, Debs.
Bye.